My name is Claire Jeffries. I'm a physiotherapy clinical specialist for hydrotherapy and rheumatology. For the last 20 years I've had the great honour of working with Axial SpA patients both in primary care and in secondary care. In primary care I predominantly work in the hydrotherapy unit, assessing and treating patients both acute and chronic, and also those that have been newly diagnosed. In my secondary care role, I'm seconded to undertake AS biologic screening and review clinics with Axial SpA patients, and also annual review for those that are not on biologic medication. I work really closely with our local NAS branch in Portsmouth, and I'm also a member of AStretch, the National Committee of Physios, working and with a special interest in Axial SpA patients. We know that within our physiotherapy clinical practice, approximately 5% of patients presenting with chronic back pain will actually be inflammatory in nature and may indeed require referral through to rheumatology. It can be really hard though to identify these patients in our busy clinics. One of the things I ask my colleagues locally to do is just really reflect back on the previous year and those chronic back pain patients that perhaps didn't respond as they expected them to the treatment that was offered, and really consider actually were these patients mechanical or were they inflammatory, and what lessons can be learnt from those assessments that were undertaken at the time. We know that these patients can be very variable and don't often fit a textbook definition of Axial SpA. They can present very much like mechanical back pains also, low back pain, some radiating buttock pain, sometimes perhaps even anterior or posterior thigh pain to the knee. But there are maybe some additional questions that you could ask in your assessment, or certainly ask more in-depth detail within your assessment. Perhaps start by looking at their previous history of back pain episodes rather than just the episode that they're experiencing at the time that they're sat with you. Very often you'll find with Axial SpA patients that they've had multiple episodes of back pain that tend to come and go, that ease a little bit after a couple of weeks, maybe with some use of non-steroidals or anti-inflammatories. And very often this is put down to a normal, natural healing process that we may see with a mechanical back pain. But indeed what is perhaps happening is the patients are experiencing intermittent episodes of flare or inflammatory back pain rather than mechanical back pain that has naturally resolved. The other thing to ask about is the patient's sleep. We know that with mechanical back pains, patients will often complain of being disturbed in the night due to pain. What we see with Axial SpA patients though, and you may find more on your detailed questioning, is that they have pain certainly in the second half of the night that wakes them, but unlike mechanical back pains, they can't just roll over, find a new position and drift off back to sleep. Very often with inflammatory back pain, patients describe a pattern where they have to physically get out of bed, they may go downstairs, make themselves a drink, they may need some painkillers, and they do that before they feel they can then go back to bed and try to get into a comfortable position and drop back off to sleep. So asking about their sleep history in a bit more detail may help you distinguish between a mechanical and inflammatory back pain presentation. The next important information to ask a bit more detail on is whether a patient has tried a course of non-steroidal anti-inflammatories. We know that a lot of patients with inflammatory back pain will respond well with decreased pain if they do have a course of non-steroidal anti-inflammatories. Please be really careful here though if you are guiding patients on medication, and make sure that you're working through your scope of practice, and if need be, refer back to the GP for advice and support with regard to NSAID use. Asking your patient about previous history or current history of the associated conditions that we see across the spondyloarthropathy disease groups may prove of really valuable information for you. So have they had, for example, uveitis, reddening, inflammation of the eye? Have they had psoriasis? Have they been diagnosed with Crohn's or ulcerative colitis, inflammatory bowel disease? We know that when patients present with back pain when they have these other conditions, it increases the likelihood that their back pain is actually inflammatory in nature. Similarly, a previous history of a one-off knee arthritis or a presentation of heel pain or TA pain may also indicate that the patient's back pain is actually inflammatory in nature because they have had previous episodes of inflammation at other joints or soft tissue areas. Importantly, in the female group, if you're suspicious that they have inflammatory back pain, don't rule it out just because they are female. We know traditionally ankylosing spondylitis was seen as a predominantly male condition, but over the last 5 to 10 years, with the advent of MRI and our greater understanding, we see an increased number of female patients presenting with inflammatory back pain. They tend to perhaps not go on to develop full ankylosing that we may see on X-ray, but certainly on MRI they're positive for inflammation. And really importantly, these females will often present with the same level of pain and burden of disease that we see in established ankylosing spondylitis. So I like to follow the mantra of one of my rheumatology clinical consultants, which was that we hope in primary care that physiotherapists, osteopaths, chiropractors, FCP will lower their threshold of suspicion of Axial SpA in female patients that are presenting potentially with inflammatory back pain. Now you may be thinking that all of those additional questions will be hard to remember or undertake within your routine assessment of your chronic back pain patient, but there are lots of tools out there that can help guide you and give you more information. Don't forget to look at the NICE guidance for the assessment and management of Axial SpA patients. They go into more detail of the points that I've just raised for you. There's also a really good resource that's quick and easy to use online called the SpA tool, and you can key in the symptoms that the patient has described to you and it will guide you as to whether they have a potential Axial SpA or spondyloarthropathy, and also prompt you to refer through to rheumatology if necessary. Remember, your role as a physiotherapist or primary care practitioner or FCP is to really build a case of suspicion for inflammatory back pain and facilitate as quickly as you can referral through to rheumatology. Now, each area in the UK probably has a different pathway through to the rheumatology consultants, and it's really important that you understand what that pathway is in your local area. It may be that you need to go back to the GP and ask whether they could refer the patient through to rheumatology. It may be that you have direct access. One of the really important things I'd encourage you to do as well is try and build some links with your local rheumatology department. It will always prove helpful if you can gain advice and guidance from the consultant or medical team in rheumatology on any suspicious cases. As part of the rheumatology referral, I'm often asked by colleagues whether they should undertake blood tests or MRI or X-ray imaging, and I think it's really dependent on your local rheumatology service and what's agreed and what's in place, and will always depend obviously on the scope of practice of the physiotherapist or the FCP or primary care practitioner. Routine bloods may help with your clinical picture and indeed help you rule out other causes for the patient's symptoms. You could ask for inflammatory markers, ESR and CRP, but please be careful with these because a percentage of Axial SpA patients we know don't actually have raised inflammatory markers. In terms of requesting MRI or pelvic X-ray to help with your differential diagnosis, this again depends on the scope of practice of the clinician, but also I think your rheumatology pathway and what the expectation is from them of what they would like to receive on a referral. So again, I'd encourage you to have this conversation with your local rheumatology department. It's really important to understand that when requesting an MRI, there are a certain set of sequences and MRI protocol to follow to ensure that they are able to investigate fully for inflammatory back pain. So in summary, don't forget to ask a few extra questions if you need to, if your chronic back pain patient isn't quite fitting that mechanical picture. Don't forget, don't rule out females as having inflammatory back pain. And also, don't forget, your role is to try and build a case of suspicion and facilitate referral through to rheumatology as quickly as you can for these patients.